Welcome back to the Physio Matters podcast in association with Rehab My Patient, and this is Emergency Session 3. Hello and welcome back to the Physio Matters podcast. We have had some amazing responses to our first two emergency broadcasts, so if you haven't checked those out, do so. You can find them across all the podcast players and of course YouTube as well. So check those out. I'm sure you know where to find our podcast if you are listening right now. So this month we have a great podcast on virtual consultations with Anthony Gilbert. So to help you along with that, our long-term sponsor, Rehab My Patient, have an amazing offer for all of our listeners. So if you head to www.rehabmypatient.com/physiomatters, and there you will be able to sign up for 3 months entirely free of all the software on Rehab My Patient. So that includes their exercise prescription software as well as their tele-rehab service, which is also available for you and also allows for group consultations or group exercise class-based contacts, so will be super useful across these COVID-19 crisis times. So let me give you that web address again, www.rehabmypatient.com/physiomatters. You just need to sign up. You don't need to enter any credit card details or anything more than that, and you will be able to access that entirely free for 3 months. So thank you very much to rehabmypatient.com for not only sponsoring our episodes, but also providing you guys with that special offer. Do get back to us on any feedback for this session. It is super practical and super helpful for anybody starting out or even experienced in virtual consultations. And I don't want to take up any more of your time, so I will let you get on with the show.
Delighted to be here today with Anthony Gilbert. We are running a series of emergency podcasts, as you'll have noticed, around the coronavirus COVID-19 pandemic, and several requests that we had, one over sort of business consequences, one over respiratory upskilling and what the do's and don'ts are for MSK therapists. We've done them, they're in the bank, they're on there. But one of the big ones as well was virtual consulting. A lot of people needing to sort of flex into this area and understand it better. What are the do's and don'ts? What are the consequences? What things can be mitigated? And there was a perfect man for that job, and a good friend of mine, someone I've worked with before on various different projects, chair of the ATOCP amongst many other hats that he wears, and someone that was also already doing some primary research into this sort of area before this pandemic occurred. And then he's really dropped a lot of that to try and help his trust and beyond to enact virtual consulting on a scale that none of us would have anticipated needing to do. And so he was the perfect man for this job. And so I would like to welcome my friend Anthony Gilbert to the show. Thank you so much for coming on, Anthony. Could you tell the listeners a little bit about yourself and how you got to this point?
Yeah, thanks very much for having me, Jack. So I'm a physiotherapist at the Royal National Orthopaedic. Yeah, thanks very much for having me, Jack. So I'm a physiotherapist at the Royal National Orthopaedic Hospital in Stanmore. I'm currently doing an NIHR funded clinical doctoral research fellowship, which where I'm investigating patient preferences for the use of virtual consultations. So I'm doing my PhD at the University of Southampton. Clinically, I'm based within elective orthopaedics, so I am combining my research with the clinical caseload. And as you say, spare time, I'm chair of the ATOCP, so quite busy at the moment. But I'm based where I work. I'm based within tertiary care, and I developed an interest in non-face-to-face consultations primarily because patients tend to find it quite challenging to get to us. And I first looked into this in 2014. I looked at the acceptability of virtual consultations, and I've carried this on for my PhD. So. Yeah, like you say, it's a topic that's of interest to me.
I think it's worth the listeners understanding exactly where you were up to before you sort of the world shifted from under all of this. So if we go back a few months and think, where were you up to before all this cracked on?
Sure. So life was normal up until sort of fairly recently. My PhD essentially is looking at trying to understand the dynamics of patient preference for those who are within an orthopedic setting, specifically with regard to when they would choose a virtual consultation over a face-to-face consultation. So I've done a couple of studies early on in my PhD, and where the study that I'm currently looking at is a quite a large questionnaire where I'm collecting data over about 600 patients. And I'm giving those patients different scenarios and asking them, in this scenario, would you choose face-to-face or a virtual consultation? And in addition to that, I'm collecting quite a large amount of demographics data. So we've got, a bit of a rough idea of what those are, but unfortunately, at the beginning of March, my PhD got cut short somewhat with the way that our trusts moved in response to COVID-19. So my study was predominantly outpatient based, so I was collecting questionnaires from outpatients. And I think it was on the 5th of March, our trust made the move to start cancelling outpatients and moving towards virtual consultations. Yeah, so that's where I'm up to.
That's where the world moved. Yeah, and so what's interesting there is that people, and that's certainly why I wanted to get you on the show on this, is because in the midst of COVID-19, there's then been MSK services forced to switch to virtual consults, but I understand there was a good evidence to support their use long before they became now a primary contact method. So what's the background and story so far for virtual consults? And in what context do we have the evidence to support not just their use, but their effectiveness?
Sure. So what I'll do is I suppose there are two aspects of virtual consultations that we're experiencing at the moment. And I would split those between telephone consultations and also video consultations. And I think it's important to point that out because actually, when given the choice, people tend to be going for a telephone consultation rather than video. Right. We can come on to our experiences in a little bit, but yeah. I suppose one of the main sort of key studies for telephone, just to start off there, would be the PhysioDirect study that was led by Nadine Foster up in Kiel, which so it was a randomized controlled trial where patients were put into telephone advice and assessment in comparison to face-to-face. And essentially, they found that the telephone consultation arm was as clinically effective as the face-to-face arm, so you can put the effectiveness to one side, but what they did find was that it was really associated with lower patient satisfaction. And there was a qualitative study by Jennifer Pearson who sort of really unpicked that a little bit more and adds a bit more meat to the bones. But within the sort of satisfaction element of it, a lot of patients found that it was really impersonal, as you can quite imagine. It wasn't the same as normal care. And what I found really interesting about the qualitative study was that patients opted into PhysioDirect as a way to expedite them into face-to-face care. So a lot of people did the telephone, but then they ended up having face-to-face further on down the line. So I suppose key take-home messages from that is that telephone has been seen within the literature as effective as face-to-face, but perhaps associated with lower satisfaction. And I think what we're seeing clinically at the moment at Stanmore is when we've given patients the choice between when patients have been triaged for virtual care, given the choice between a video and a telephone, a lot of patients are actually opting for telephone, which I didn't really expect. I thought more people would go for video. And this is across the trust with sort of surgeons, doctors, but then also with physiotherapy. We've got a high number of patients that are actually going for a telephone call.
Is there either a research understanding or just your personal subjective understanding as to why that might be?
I don't think this. I'm doing a PhD in the area, and I've tried to keep on top of the literature as much as possible. Amazingly, the last couple of weeks, Twitter has just exploded, and there are studies coming out of various corners that I'd not heard of. So I think there's a huge amount of discussion going on around this. But personally, I think that the idea of using a video consultation for someone that maybe hasn't been through it before, doesn't really know what to expect, and given that snap decision they're required to make when an admin staff phones them up and says we're changing to virtual, choose a telephone or video. I think people are just opting for the thing that they know the best.
Yeah.
And what we're finding is that when people have a telephone consultation, they need a follow-up. We are getting a bit of conversion to video. And I suppose when the clinicians are able to talk to them somewhat and say, we can do it like this and explain it a little bit more. I think what I need to point out is that in this current situation, our admin staff across the entire trust are doing en masse phone calls trying to convert these appointments over to virtual. And it might just be that particular split-second decision they need to make, and that's what they're going for.
Yeah, it does make sense. It's a much newer, much more novel interface that people aren't going to be as used to. And so in that moment, they're likely to revert to a comfort zone. And in this instance, telephone would be more comfortable than Skype and the like, video consult for the most. So no, that does make sense. We've sort of touched on some of them already, but not necessarily explicitly stated what we think they are. But what are the strengths and weaknesses of virtual consulting, do you feel?
So I suppose I find strengths and weaknesses as a thing quite a difficult one to say, because I think that a virtual consultation is quite situational and it's very individual to the person. So what might be a strength of a consultation for one person might not be for another.
Right.
But I suppose in general, if you could touch over it, I mean, if you have a virtual consultation, a patient they don't have to travel, so they can avoid that. And I suppose within that can reduce the costs of travel for them or societal costs from the actual physical getting there, whether it's their own petrol, whether it's public transport fees or anything else, taking time off work or having to put their kids into childcare or something like that. I suppose that could be perceived as a strength. It could be more convenient for patients. What I found in the past when we've researched this is, particularly when giving patients the option of having a virtual call, they were quite surprised, or they were able to articulate how much pain they would be in from having a long journey, particularly in tertiary care. So what you find is a patient presents to a virtual consultation, they're not in as much pain and they may be able to engage a little bit more.
Right.
On some of the research that's been out there, sort of I'll direct you to Trish Greenhall's Vocal Project. They found that patients were talking more than what a clinician would do. So I think clinicians maybe have to listen a little bit more to what's been said. And that sort of flies in the face of what Lisa Roberts worked at a few years ago, where she was looking at the percentage of time a patient and a clinician would be having a conversation during that. So it might give a clinician an opportunity to listen a little bit more, or be forced to listen a little bit more to the patient. Obviously, from a weaknesses point of view, there are some things you just can't do over a virtual consultation. You can't touch the patient. Some clinicians might be absolutely fantastic when they're in their clinic, in their world, in their arena. But when it comes to the fact that, or if they find that they are unable to log in or find it difficult to even click a mouse, having that conversation in a virtual context can be quite challenging for clinicians and for patients. It might change that power balance ever so slightly. As we're finding at the moment, as we're rolling these out, technology sometimes fails. I demonstrated this spectacularly a few weeks ago at a conference when I was trying to do a live Skype consultation and the Wi-Fi cut out.
Typical.
It can really interrupt that, the interactions that a patient and clinician might have. And particularly when you have lag or you've got a frozen screen, this can be quite difficult as well. So I suppose there's a bit of a balance to be had there, but there obviously are some strengths and are some weaknesses.
I think that you're right in that strengths can be weaknesses and vice versa on this. And one of the most fascinating things that I've noticed from discussing, obviously we've done virtual consulting for quite a while because of the circumstances of second opinion work that we sometimes see here in private practice. But the big thing that we always notice is that depending on the circumstance, depending on the existing relationship or the style of interaction that the therapist and that patient might fancy, it can really be something that it can really enhance a conversation because of the context being different enough that interruption is more overt when it's either the phone or video than it is in person. There's almost like subtle social cues that you can you can use that means that interruption seems less abrupt and therefore feels more tempting for therapists to try and get someone back on track. And so even things like slight delays or an expectation that this is novel makes people more balanced, and that is very useful in most contexts. But then in other circumstances, when there is sometimes more overt safety information to deliver or specific protocols or guidelines, I'm speaking to orthopedic surgical colleagues that are saying that sometimes the fact that there's useful leveling of the playing field for some of their persistent cases or follow-ups, sometimes where they need to deliver some really specific do's and don'ts. They said that admittedly they do need to lean into a power dynamic where they are being authoritative, and sometimes the fact that the patient sat there in their PJs isn't always helpful for them to try to be able to make that stand. So I can so understand why you said that it's sort of for strengths, weaknesses, opportunities, costs. It's never straightforward as this, is it? They're just different. There's some similarities, but we've just got to try and work out how to best move forward, understanding this new medium as quickly as best we can. So with regards to some of the challenges we've described, can you think of other sort of your top tips for how to mitigate them?
Yeah, so and this is something we've been doing very recently, as we are sort of having a rapid rollout of virtual clinics. But I think the main thing is, and particularly for us as physiotherapists, I think there's a huge amount we do to build that rapport with our clinicians. But it's really making sure that you are able to come across in a way that demonstrates that empathy that we normally would do. If you've got your webcam set up, I think there's a lot of preparation that goes into it. You've got your webcam set up and you're looking to the screen to the side, and then all a patient can see is your ear or the side of your face rather than looking into your eyes. That's quite challenging, and we found that from our previous research and other research around as well. It's really important to be able to set almost the boundaries of the consultation. If you are someone that is trying to guide and facilitate that conversation, to be able to say, this is what, introduce yourself, this is what we're doing, this is how we're going to move forward. And there's almost a set boundaries that need to be made at the start of that. And I think it comes down to what you've got in front of you as well. So what is actually needed, what are the goals of the consultation. I think it can throw people being in a new place. Well, certainly some of my colleagues that I've spoken to, it can be quite unsettling when you've got a new world and new arena in front of you. But I think quite quickly people get used to it. And on the flip side, it's quite challenging for patients as well. So there is an element of clinicians still needing to lead that conversation and still needing to lead what is happening moving forwards. That is quite challenging in a completely new way.
Do you suggest to your colleagues that they do try to still set some of the parameters of the conversation or the consultation, where they still, if they were to set the scene normally, as soon as someone sits down in their clinic room, go through at least some of the same patter as it's relevant, so that then they don't, so that just because the technology is novel, the consultation can be made more familiar, can't it?
Yeah, I mean, I think the clinicians have been very good at just leading onwards and leading forwards with the way they normally would do. I think there's that initial maybe discomfort, or you're looking around and you're seeing the world behind the patient, and you do get some patients who might be lying on their bed or have got posters up behind them or whatnot. into your patter in your talk, and then things seem to proceed on from there. I mean, absolutely. I mean, I'm not going to tell my clinical staff how to do their job, and they seem to have found quite a nice balance. But there have been times where it's more from the patient end when they tend to have gone off. You're deformalizing the encounter and the interaction, and that has led to some challenging conversations that were challenging, but have led on to conversations that you normally wouldn't have if it was in a cubicle. And it's just being able to bring those back and to be able to be assertive with that. And I think people have generally been able to do that quite well. I mean, we've had people doing consultations in their car. We've had a patient based at a theme park, out for the day doing a consultation. We've had people in busy corridors and in shops. So I think there are ground rules that need to be set probably right at the beginning. And these are things that maybe shouldn't be surprising, but actually you almost create this environment where you are deformalising that consultation and setting those boundaries is possibly quite important.
Yeah, no, it's a great point, especially. There's a difference between a virtual consultation and a phone call with a patient. That we've all made phone calls to patients that we'd otherwise see in person, and we wouldn't expect much from that. If they were out and about, we're just appreciative that they answered the call, or they might have made the call, and the context is different. Whereas an actual consultation, where each other's undivided, is a different circumstance. So that's a really good point. One of the questions we've been asked regularly, and I want to feed forward to you, is there any specific consent we need to gain, or anything that's particularly different in that realm?
So I think with regards to consent, I mean, the way that I've always done is a patient rocks up to your outpatient clinic, and I suppose there is a level of implied consent of the fact that they've turned up, and I think there's a level of implied consent if somebody logs into a computer and virtually attends. That's almost the same. I think where things get tricky is if you're starting to record conversations or consultations. When you phone up or somebody phones you and it says your call may be regarded for training purposes, that's informing you that it could happen. So it's illegal to record a conversation over the phone without that other person knowing, from what I'm aware. So if you are changing the way that you would do things like that, then it's important to say, are you recording this, or do I have your permission to record this? We're using this for the patient notes. I think normally when you have somebody attending your clinic, it's pretty obvious if they've got someone there with them. So you have two people coming into the cubicle, but you could have a whole load of people that are in the room at the patient's end and at your end. And it's probably important to be able to have that conversation first up and say, is there anyone else in the room? By the way, there is somebody else in this room. Is that okay with you? So again, It sort of comes down to establishing those ground rules and boundaries. Now, I can't really think of what potentially the consequences could be of having somebody else in the room overhearing it. But if you were to have someone eavesdropping in a clinic-based environment, that wouldn't be acceptable. So I suppose it's the same thing virtually as well.
No, for sure. Yeah, it needs to be the consent needs to be as detailed as is necessary, and you don't know until you ask those sorts of things. It's a really good point. There could be other people in earshot in a different way that you wouldn't be able to notice as easily virtually.
And I think for us, if we are recording anything, then there's a separate signed consent form, that, like a multimedia form, that patients would need to sign if we were doing something, whether it was research or clinically as well. And I think they're probably the things that, as we're sort of having this shift and wave towards virtual consultations, and I've had people say to me, "Oh, how do you document? How do you record these things? Can we just record it, and can they be the no's?" That's down to the individual clinician or the individual practice, but it's probably worth bearing those things in mind.
Yeah, I think as well, when it comes to recording stuff, I think that people sometimes are a bit clumsy with their understanding of the technology. It's saved to? Is that to a device? Is that device secure? If it's to a cloud, where does that cloud land? It's clearly in a server somewhere. There's no such thing as a web cloud that doesn't have. It needs to touch terra firma somewhere. Which country? What are their IG procedures? So sometimes people playing fast and loose a little bit with things that they wouldn't otherwise do in face-to-face. So pressing record is something that brings with it a whole load more baggage that people need to be a bit more thoughtful of than they currently are doing. With regards to some of the technologies on that, I definitely want to come back to how we can mitigate that, what you would recommend and what you would say you're using. But on the actual consulting front, I just want to make sure that we're clear then as to any particular advice you have for building a therapeutic relationship and rapport. You'd mentioned sort of the angle of your camera and things like that. I think it's a really good point. But is there anything else that you feel we could bear in mind as we try and get used to this?
Yeah, and I think I've come across, just from my own experience, but then also reading across the literature, I think if you're on a phone and you've got a patient talking for long periods of time, I think an ability to certainly create the impression that you're listening, so whether that's dropping in a or yes, so that a patient knows that there is someone at the other end of the phone. It's so impersonal if you've got a phone to your ear and you're not hearing anything back. So it's anything that you can do to make the patient feel, or whoever it is, feel listened to. So that could be on the phone. I think when you're doing video type calls, some level of gesture, nodding, smiling, in the same way that you would do in a face-to-face consultation, something to reassure that you are listening and you are engaged with the patient. I mean, it's obviously over a screen, things are going to be different. Speaking to a two-dimensional screen where you've got someone on the other end compared to what you would have in front of you, it will be different. But it's the same. I suppose it's the same rules apply as you would do. I mean, how would you demonstrate empathy normally? I mean, it would be with facial expressions, it would be with hand gestures, whatever that might be. But you can still do that over a video as well. It might be you're a bit more, over the top with your hand actions to convey that message, or smiling and getting your teeth out a little bit more than what you would do. But I think anything that you can do to convey that is important. And you can still build a rapport over a screen. You can do. But you can also quite negatively not build a rapport and actually make things worse and make people feel that they're not being listened to. If you're sitting back like this and you're looking up in the air, or something like writing your notes, if you are sitting there scribbling, writing your notes, and all they can see is the top of your head, something simple as, would you mind holding on for a second? I'm just going to write my notes. I am still here. I am still listening to you. Just bear with me. I want to get this down because it's really important.
I think that's one of the things that's making people tempted to say, well, if we just recorded this, then that could be the notes. But fundamentally, if that was a facility that you had in clinic, then that wouldn't be the utility of the notes anyway. There need to be an abridged record of it so that you can tap back into it, because there's no way that you're going to watch the entire consultation back in order to remind yourself of your next visit, so to speak. And that's why I think that people, I can understand the fact that people don't want to come across as if distracted by their documentation, as is a problem, of course, even in face-to-face consults. But the instinct to then sometimes say, well, I'll just record it as if it's the whole thing. That's not what your documentation would normally be, and nor should it be here, in my opinion.
Correct. I agree with you. And I would, particularly now when we've got this virus traveling around and you don't know who's going to get it next, and the consequences of getting it means that you're going to be off and out of action for a period of time, I would question how someone is going to come in and pick up your caseload if that's what's needed to do. If you're looking through the archives of some video elsewhere, I mean, you notice that there is a record of what happened. It's a legal document, and there are guidelines out there on how to do it. Maybe in the next, few years, who knows, there might be virtual documentation or note keeping that, guidance on how to do that. I mean, it could be quite useful if you're able to record, if you're looking at someone's range of movement or lifting their arm up, to be able to take a snapshot of that if you follow the procedures that your clinic have set, and having that stored or captured as a multimedia addition to your notes. But the way we're doing things is it's done in the normal way, in the normal practice. You follow the normal protocol. I don't see why doing a phone call or a video call would change that process.
Yeah, we don't want to lose the sort of fundamental governance underpinnings just because of the unprecedented nature of the circumstances we find ourselves in. I think sometimes we can just take an opportunity to sometimes get carried away in that direction, and I think that's a good example of it. It would be literally impossible, because if someone was to come into your clinic for tomorrow and need to, they've got a list of patients, they literally, of course, do not have time to watch yesterday's, because of the nature of that being a whole day's worth of consultations. It's physically impossible for them to ever catch back up. And so just as you wouldn't expect them to understand exactly verbatim what was said before, your documentation needs to be of an appropriate brevity for them to pick that back up. So I think that's a really good point. And with regards to the specifics of what is being demonstrated in an MSK context, it would be disappointing if you weren't able to gauge, or if you haven't got facility to record someone doing a movement, then it'd be disappointing if you weren't able to gauge, at least on video, what their range might be, or even over the phone for them to describe it by some way of landmark would be useful. Now, I want to get into some of the weeds on this. Some of the limitations, let's say, that are obvious with regards to your inability to palpate things and touch, which, as you know, a lot of our listeners, the vast majority of our listeners, are MSK therapists of various different stripes and flavours. And so a couple of examples we're thinking of is, say, wanting to palpate a knee joint line. Obviously, someone like yourself in orthopedics would be a valuable thing to do. And also reflex testing, both in and out of serious pathology, but neuro screening. In circumstances like that where you can't do tests that you would otherwise, let's not hope, rely on, but certainly include in your framework of reasoning, what would you suggest to people as to how to mitigate those challenges?
Sure. I mean, I suppose, you cannot assess someone using your hands over there. But what our guys have been doing is getting patients to self-assess. So if they're able to, if you say, you can describe if you feel your knee and if you feel the crease at the back of your knee and you can work your way around to the inside and give it a push, for instance, just a palpation. Patients can do that and describe it. And there's been some evidence in the past of the virtual outreach project, which was early 2000s, where actually specialist clinicians could quite successfully do virtual assessments with a general practitioner there as well. So that there is potentially a way that you could talk through an assessment if they have a member of their family there or something like that. But if they don't, then it's quite challenging. And I think if we look at this now, we've obviously got this COVID situation, and then there's the risk and balances of bringing a patient in. And I think everyone would suggest that you don't bring a patient into your clinic at the moment unless it's absolutely essential and you've got the right precautions and everything else. But really, I can't see many situations where that would need to happen. But moving forwards outside of this, if you need to assess someone, if you need to put your hands on someone in order to do that, then a virtual consultation may not be the appropriate choice. Yeah. That makes sense.
Yeah. No, I remember in prep for this interview, I know me and you were discussing the fact that the answer always needs to lie in the entire background of your reasoning. And if you're over-reliant on a particular hands-on special test, even if that was something like a joint line palpation or a reflex, then you're not nestling that appropriately within its wider context that would support your reasoning. And so sometimes in clinic, that can be a real thing that sort of brings it over a line on a differential diagnosis. But it's very rarely the only thing, and certainly not something that's insurmountable, especially in this circumstance we find ourselves in, where safety is paramount and the fact that there's a good reason why these things are being done virtually. And so that is a compromise that has to be made, unless we're getting into the realms of serious pathology, and some of those tests would be indicative of whether or not this needed to be escalated regardless of the circumstance. Now, those instances are things like red flag pathology, PR testing, and perianal tone and the like for cauda equina are things that certainly you want to be you can only ask a certain amount of subjective questions, for sometimes those things need to be bringing in to A&E departments even in these circumstances. Obviously the triage of that and the safety netting of that is of much more importance, because we want to try and make sure we don't put well people wrongly into the system. But generally speaking, if we were to, we don't want to play fast and loose with these problems, which we've covered on this podcast many times. So what's the latest sort of guidance on what do we do if we detect red flags in these virtual consultations?
Well, I mean, I'm not actually, I'm actually not aware of any guidance currently in relation to virtual clinics. And I think it just comes back down to what would you do in a normal circumstance. So as an MSK professional, if you're subjectively detecting that there may be things that need to be investigated, it becomes that risk, the risk benefit then of, do I make an onward referral? And if you're potentially identifying that there is that there, then you would make that onward referral. You would need to make that onward referral, particularly in an emergency situation. That's my understanding of it, but I think I'm going to bring it back down to that individual clinician and their clinical reasoning. There are some things you can't do virtually, obviously, but you can question, you can ask, you can pattern recognise. And I think what is probably really important at this particular time is recognising that us all as clinicians are working in different ways, and across my department there are conversations happening all over the place. Oh, I had this, we had this. And I don't know if there's any way to be able to share information or have, almost like peer support or clinical reasoning discussions about these as they arise. I think the bottom line comes down to safety, doesn't it, at the end of the day? If you're detecting something that you suspect needs further investigation, then that onward referral would have to be made. And there are, there are obviously still emergency services that could potentially take, that would take those patients in that situation.
Yeah, one of the things that's been useful, because you're absolutely right in that it's not necessarily specifically about virtual, but as the circumstance unfolds, and we are all thinking sharply about who we send out, not just into services, but also into the wilderness, that actually we're suggesting leave their home under medical guidance, then we're all being a bit more thorough with regards to sort of, and a bit sharper on that triage. But one of the things that's been really good, that's been produced by NHS England Improvement this, I think it's the last week, is sort of offering the parameters over what would be serious pathology and how these things need to be managed as they have been. So Laura Finucane and others have produced this document that's then outlining conditions and circumstances that need to make sure that they get escalation regardless of how that person comes into contact with the health system, and also just helping people. Although there's nothing, especially to listeners of this podcast, there's nothing specifically new in the clinical guidance there. It's just making sure that people are aware that these are the sort of parameters that you need to be mindful of even in these circumstances, and then offering the guidance as to what would fall in and out of scope as being emergency and urgent. And I think that's really useful, and we'll make sure we link listeners to that in the show notes to this and across social media. So no, that's great. And as ever, reasoning is king, and don't play, just because the circumstances are different doesn't mean you want to be feeling bad about having what you've missed. If anything, it makes good clinicians rise to the top, and making sure that we're sending the right people in for the right care becomes ever more important. So people can't be just playing fast and loose with it and sending everyone in. Your reasoning is going to be ever more important in this difficult time. I wanted to ask that, aside from the note-keeping aspect, which we've already covered, in terms of information governance, what factors is there to consider, and is there anything new in that remit since the COVID crisis has been upon us?
Sure. So the first thing I'll say to that is our experience of offering virtual clinics. We've got an information governance department they're experts in that, and they've conducted a privacy impact assessment for patients. I think if you've got the capabilities to do that, that's really important. So you consider where potentially information governance may change with regards to management of data. NHSX have put out some guidance quite recently in response to COVID-19, where they've essentially set out that they encourage use of video conferencing consultations where possible to stop people having face-to-face. And they've said that things like WhatsApp, or I think Telegram is the other example, or FaceTime, always there's more personal mediums, whilst not ideal. If the risk versus benefit is that you use those in order to access patients, to use them for care, this is fine. That may well be dropped down again at some point in the future, but essentially being mindful of managing data in the same way that you would do. So if you're doing your virtual clinics from home, it's thinking through things like storage of patient information. I don't know how people might do paper notes. There'll be you would need to consider this and consider the policy locally, whether you're in the NHS or in a private practice, but manage them in a safe way, where you're not potentially jeopardising personal patient information.
Yeah, I think that's something, especially those that are making paper notes, or even on a virtual consultation, suddenly people might find themselves, and I know I've been in this situation where I wouldn't normally be making notes on Post-its or in a normal consultation. For some reason, it's just flowing and my memory feels better. Whereas over a video, because of the difference in circumstance, I might make a few notes. Now, if there's ever any patient-sensitive information on those notes, then I need to be making sure I'm mindful as to how they're being stored. Just the fact that if I got burgled that day and something got scooped up with a laptop bag, then you still need to be making sure that privacy is of the paramount importance, because you would never be taking sensitive notes home with you and feeling like that wasn't your responsibility if they were to be taken in some sort of burglary or other situation or loss. So I think that's useful. We don't want to compromise our fundamental values of patient privacy, even though these circumstances are unprecedented. Interesting that NHSX have, I wouldn't even say laxened, but certainly been more understanding of own device use, things like WhatsApp, recognising that the opportunity to try and reach people wherever they might naturally be or with apps that they already have is is, I think, a very sensible and mature approach to things. Although you're right, I think they may well tighten that back up for good reason once best case can be used, and that sort of brings me to best case, because one of the reasons I really wanted to speak to you is because as a person, but also within support of your organisation as a tertiary care centre and such a specialised centre, there is you end up with use cases that are of closer to best practice, I would say, than other people that are having to play catch up and have no legacy of any virtual consulting. And so how have you readied your service, and what software and systems do you recommend others use for virtual consulting in the meantime as they adapt?
Sure. So I think the first thing I'll say is every service is going to be different. If you're a one or two clinician private practice to a massive buzzing therapies department. But I suppose I've been the last few weeks I've been working within a non-face-to-face team across the trust. We've been sort of tasked with facilitating conversion of face-to-face to virtual consultations. And so we've just been through a process where clinicians have been asked to screen their lists and identify patients that could be virtual as opposed to standard care. We've had a huge amount of support from our admin staff who have made those calls to patients, who've gone out there and said, look, we explain the situation and have asked them to choose either a phone call or a video call. Part of my role has been supporting with training to get clinicians up to speed with the actual how to use it. Things like setting accounts. I'm running around with bags full of headsets across the trust and things like that. But we had 11 days from operating normally to having the whole trust across 2 sites achieving at least 80% virtual consultations. There's been a huge amount that has gone into that from that perspective. The software that we're using at the trust is something called Attend Anywhere, which has come from NHS Scotland, and I think there are more trusts in England that are now using Attend Anywhere now. And I suppose it's a really useful and easy, he says, software to use. So for a clinician would just need to log in, and then they are at a virtual waiting area. For a patient, they will need to click onto a link, input their details, and then will be in the waiting area, and then the clinician will pull them through. And it seems to be working okay. I mean, obviously, there are times where things don't work. The internet at times can be a bit fuzzy, all around the country. So a tertiary centre, internet can be a little bit in and out, but the same sort of problems that people normally have. In the past, we've used other software, so we've used Skype. There have been a couple of consultations that have been used over Zoom, and I think it doesn't really matter what the software is that you're using. I think there's probably going to be a threshold for patients who are going to be able to access it or not. That's my own thoughts from the experience over the last couple of weeks, and I think there's some really key learnings, or key things we've learned over the last couple of weeks. I think everyone makes assumptions that certain demographics of people will be able to access the technology and to be able to do it, but actually some people find it really challenging. I'm someone that uses Google Chrome. I don't know what browser you use, but there are a lot of people that use things like Internet Explorer or Firefox, which don't seem to be supported by some of these, or certainly Attend Anywhere. So I've spent quite a long time talking to people over the phone whilst they're in line for their consultation, trying to get them to download sort of more up-to-date software. There are lots of people who have iPhones who don't have the up-to-date iOS. And so there is a threshold or a minimum threshold of software and hardware that patients need to have in order to use these things. So our IT department went through a whole systems upgrade of all of our computers pretty much overnight. We installed a load of headsets, webcams, and everything else. So that was quite a quick and fast response there. But although we are ready as a hospital, the patients at the other end weren't necessarily as ready, and nor would you expect them to be under normal circumstances. And I think, that might be one of the one of the challenges that people will have, is that although the NHS or private practice might have up-to-date equipment, I'm going to say up-to-date, it's the NHS, as up-to-date as you can be, but across the population there are many people who don't, and that person will still have a knee problem or a back problem or a shoulder problem and would still need to see their physiotherapist. So although we've done as much as we can our end to get ready for it, there's still a bit of a gap there for some patients.
And I think that's one of the things that we will start to see as we witness, both locally and cumulatively nationally, as well as beyond, the fact that these are circumstances where the same sorts of glitch or issue is going to come up, and so the same sorts of fixes could be produced. So crib sheets which give detail, especially those that can be sent over email or the like, that can give clickable links for downloading certain browsers, even a bit of knowledge as to what a browser even is. There's people that have used Internet Explorer since it started, and that for them is just perceived as being how you access the internet. You click on that E, and therefore the fact that they wouldn't even know that that's a browser, if you sent them a link saying download a different browser, they wouldn't even know what you're on about. So this important sort of crib sheets, I imagine, that are going to emerge from this, and detailing for people as to how we can speak lay language across generations, across industries, to try and make sure we join this up. And I think it's not going to be something that's going to be as quick as it maybe needs to be right now, but certainly we'll come out the other side of it more adept and virtually competent, I would say, by the looks of things. So it's through the work of you and your colleagues that's helping us get ahead on this, which is really appreciated. I wonder if you had any final thoughts, Anthony, and also please do let everyone know as to where they can find out more about you.
No, I think that's covered quite a lot there. I think it's a really difficult and challenging time for physios. I'm seeing that, experiencing myself sort of back into the clinical mix, seeing that with my colleagues, having to do things differently, and I think it's been absolutely fantastic to see the way that people have responded. So, I think as a group we're doing really, really well. I suppose my take home messages that I've learned over the last couple of weeks is that this actually isn't easy to transform what you're doing, face-to-face care to virtual care when perhaps it's not been done a massive amount in the past. It's very new to people. It is really difficult, and I think it is really frustrating. And there are some really good examples that you can see on social media, examples of people that are doing really good work with transforming over to virtual. But I'd say for the people that are struggling with it, it is really difficult. And I think there's the potential for people to feel like they're not doing as... trying to think how to explain it. Potential for people to feel that they're letting their patients down, or you feel we operate as we're caring, we're empathetic. We really want to see our patients and to work with them and to make them feel better and to help them improve. And I think one of the real consequences of doing things virtually, when it's forced in the way it is that for patients, their satisfaction isn't going to be as high as what it would be normally if it was in a normal routine way. But also for clinicians, it can be really negative for clinicians too, because you want to do your job, but then all of a sudden you're having to do things differently. And I think that's a really important point to make. And for anyone, I think there are, and I'm probably guilty of this by putting out the odd tweet saying, "Oh, wonderful, we're doing video consultations and whatnot," and I'm part of a team that has been tasked to do that as part of a big, quite a large organisation. And you put the positive tweets out, which I am guilty of, and I see others that are putting the positive ones out as well, and everything else, and it can create this illusion that upscaling or changing to virtual consultations is really easy. I think the point I want to make is that it's not easy and it's really hard. And I think if people are struggling, or if the technology isn't working, or if you need to abandon it and go to a phone call, video call isn't the only way. I think you can still deliver a lot with the patient, or you can still get a lot across with the patient just over a phone call. And I think that's something that we need to remember as well. It's not all about video. I think during this really difficult time, a telephone call is often enough.
Yeah, there's some vital consultations that are going to take place over the telephone in imperfect situations, and they're going to be really appreciated by our patients. I think it's a really lovely point that you're making about the fact that if you're finding it hard, then that's okay, because it is hard. Sometimes it's good that we can lead by example sometimes and demonstrate the at least technological ease that it can be done if you find the right things and find the right people that can move quickly on it. But fundamentally, it's something that takes a lot of adjusting to, and some teething problems are inevitable, including interpersonally. We've got to give ourselves a little bit of space to try to adapt. So I do really understand that. How can people find out more about you and get in touch with you, mate?
So I'm on social media. So my Twitter handle is at awgilbert11. I have a website for my PhD project, as it was previously. It's probably going to change quite a bit now, but that you can see that through my Twitter handle. My PhD is called the Connect Project, and as I'm starting to get stuff out there, I'll be publishing what I can on the website as well.
Yeah.
So yeah, and if anyone wants to get in touch and talk to me from this, then feel free to divert them onto me through.
Yeah, please get in touch with us and we'll point them in Anthony's direction. Thank you so much for the work you're doing, as well as for taking the time out to chat to me today and feed this information out to the thousands, especially at a time where your time is incredibly precious, as it is for all the therapists that are especially London based right now, but particularly in the NHS. So thank you so much.
Thank you. You've been listening to the Physio Matters podcast, discussing physio matters because physio matters.
Lovely.